Okay, everyone, welcome. We're going to get started here promptly at 10 a.m. Eastern Time. I want to welcome everyone who has joined thus far. We will probably have people joining here in the next 5 minutes coming in. And I just ask as you join that you mute your microphone upon entering the room just to minimize noise and echo. And we will have a time where you'll be able to submit questions, and I will go through that. There is actually a chat box in the top right-hand corner of your screen that you should see. And in that chat box, you'll be able to submit questions that we'll be going through, time permitting, and try to get through as many of them as possible for our speakers. But I want to welcome all of you that have joined us. Some of you pretty early in the morning, if you're joining us from the West Coast. This is obviously a really important topic and something we wanted to bring to all of our supporters that make our work possible. To start off, my name is Don Orico. I'm Director of Strategic Partnerships with the Mackinac Center. I am actually based here in sunny Tampa, Florida. I work nationally with the Mackinac Center on many of our policy issues that we've taken on a state-by-state basis, but particularly labor reform. And this series of events that we're bringing to you is our way of trying to keep you in the loop, keep you informed as to all the things that the Mackinac Center is doing to address the ongoing policy issues that are happening at a breakneck speed all around the country, and what Mackinac is doing both in Michigan and around the country to address those issues. For those of you that don't know, and many of you probably do, the Mackinac Center is a Michigan-based think tank, nonprofit think tank that focuses on advancing policies of free market and limited government. And while we work and have made a lot of our history in the state of Michigan, we are also working all over the country on a variety of policy issues like labor reform and healthcare policy that impacts Americans in every state. And so this first event is going to be an event that talks about healthcare policy and what the Mackinac Center is doing to contribute to solutions during this ongoing crisis for all Americans. So first I want to introduce you to our speakers, and we will have this set up where it'll be a Q&A format between myself and the speakers, and then as I mentioned, there'll be a time for our guests to submit questions for the speakers as well. Our first speaker is Lindsay Killen. She is Vice President of Strategic Outreach and Communications for the Mackinac Center, and we're going to be talking with Lindsay about the efforts she is spearheading regarding healthcare policy. So Lindsay, thank you for joining us today. We're excited to have you. And first question for you right off the bat is obviously there have been a lot of emergency orders that have come down from the governor of Michigan that is changing the way people can access and receive health care during this crisis. And we're seeing this all over the country where the private sector is being activated, regulations are being cut to expedite the process of getting health care and pharmaceuticals into the hands of people that need it. Tell us more about those executive orders and why they are so significant.
Sure. Thank you, John, and thanks to everyone for joining us this morning. So as the COVID crisis escalated over the last 3 to 4 weeks, I'm probably more than a month ago now, the Mackinac Center put together a very short list of healthcare-specific policy reforms that the governor could adopt immediately via executive order that would have a direct impact on providers addressing the COVID threat. About 48 hours after those conversations began, the governor issued her first in a series of executive orders that included most of our most significant recommendations. So among those reforms that we recommended, Governor Whitmer has enacted a suspension of certificate of need laws, which have historically limited the ability for healthcare facilities to expand hospital beds, general capacity, acquire critical equipment like CT, MRI, and PET scanners, for example. And this is really significant for a couple of reasons. The first being that Michigan's CON program has been one of the most far-reaching nationwide. And secondly, no state has completely lifted their certificate of need laws since a slew of states eliminated them over almost 3 decades ago now. So this sends a very strong, very significant signal for what can be done more permanently. Secondly, she suspended restrictive regulations for licensed medical personnel, including barriers to telehealth access and operating across state lines. And finally, she suspended some scope of practice limitations for nurses, pharmacists, medical technicians, nursing aides, medical students, and even childcare providers. So that was very expansive in its scope as well.
Let's talk about one of those in particular, and that's certificate of need. A lot of people are not familiar with that term, even if they are people that follow healthcare policy. Certificate of need is a new term for a lot of folks. I know here in Florida, it's been a big issue for us up until last year when a number of those laws were finally repealed. But talk about what happened, and what certificate of need is, and what is happening in Michigan specific to certificate of need.
Sure. So more than 4 decades ago, Congress actually passed the National Health Planning and Resources Development Act of 1974. And that statute enabled the federal government to withhold federal funds from states that failed to adopt CON regulations in healthcare. So New York had already enacted the first Certificate of Need program in 1964. That was 10 years prior to this federal action. And by the early 1980s, with the federal government's encouragement, every state except Louisiana had implemented some version of Certificate of Need. Policymakers had hoped that these programs would restrain healthcare costs or increase healthcare quality and overall improve access to care, especially for the poor and underserved communities. That's not really what happened, though. In 1986, after Medicare changed its reimbursement practices and as evidence mounted that CON laws were failing to achieve their stated goals, Congress actually repealed that federal act and eliminated federal incentives for states to maintain their CON programs. And at that point, 15 states, representing about 40% of the U.S. population, completely did away with their Certificate of Need regulations, and many since then have at least pared them back. A majority of states, of course, still maintain CON programs, but those are vestiges of this National Health Planning and Resources Development Act that can no longer be justified and was ultimately repealed at the federal level.
So do we know approximately how many more hospital beds and imaging machines that Michigan facilities would have had to combat COVID-19 if we didn't have these laws in place prior to this crisis?
You know, conservative estimates put the projection of the number of hospital beds we would have had if not for CON at around 4,000, which is not an insignificant number. But really, the number would more likely be close to 8,000, maybe even 10,000 more hospital beds across the state. And the ratio of available beds would increase more in rural areas of the state where right now access has been even more limited. And it's also worth noting that quality of care also increases when CON is removed. So, for example, a study done by the Mackinac Center found that post-surgery complications in Michigan would decrease by over 5% without CON, which is a medically significant variable. Additionally, we would have about 15,000 more MRI machines, 20,000 more CT scanners, and about 150 more PET scanners in the state simply by removing these arbitrary barriers.
Thanks for that explanation, Lindsay. I want to transition now to our other speaker, Greg George, who's a senior research fellow at the Foundation for Government Accountability and is working with the Mackinac Center to address many of these issues in Michigan and around the country. Greg, thanks for joining us. I want to turn this over to you because, like Certificate of Need, there have been many changes to scope of practice limitations that empower Michigan medical personnel to provide greater ranges of care. First off, what are scope of practice laws? Why do they matter, especially in a time like this?
Sure, and thanks for the Mackinac Center for inviting me on to be here and discuss these awesome issues. That's a great question. And scope of practice laws most often always come down to how much autonomy a healthcare professional has when providing care for their patients, regardless of training, education, or experience. So more specifically, scope of practice laws are regulations that restrict what tasks, say, nurses or nurse practitioners, physician's assistants, pharmacists, and other essential healthcare providers may perform while caring for their patients. And another way to think about it is that scope of practice restrictions prohibit healthcare providers from practicing to the full extent of their training. So, for example, there are different types of restrictions in relation to, say, nurse practitioners and physician's assistants that states have historically enacted and enforced. One is the restriction on the ability to prescribe medication. Another is whether an NP or a PA is required to work under the supervision of a physician. So the supervision requirements act essentially as and limit the flexibility of those providers. What is interesting to consider is why these restrictions are even in place altogether. So opponents argue that it's a safety issue for patients, but evidence shows that nurses and physician assistants can perform just as well as doctors in terms of patient outcomes. And so you're seeing that even NPs and PAs, the outcomes are very similar to doctors. And in some cases, if you look at patient satisfaction, which is another very important thing to consider when you're talking about healthcare, studies frequently find that patients are more satisfied with consultations with nurse practitioners than those with doctors. I know that I often go, whenever I go to see the primary care or to go see the doctor, I often see an NP, and they do a fantastic job, often never even seeing the doctor. Now, as far as why this matters, the other part of your question, it really comes down to the fact that these rules are restricting the supply of primary caregivers and other really essential providers, which is particularly a problem in rural areas and especially during times of this healthcare emergency. So fewer choices for patients and consumers means higher costs, longer wait times, and accessibility issues. So patients have to drive a lot farther to go see a doctor. Scope of practice restrictions have significant impact on healthcare delivery during health emergencies like this one, especially as professionals contract the virus. Hospitals and clinics are overwhelmed and pushed to their capacity limit. This is why we've seen several emergency suspensions of scope of practice laws across the country, including here in Michigan. And Governor Whitmer's order specifically allows PAs to provide care without a written practice agreement with a physician. It also allows NPs and nurse anesthetists to provide medical services without physician supervision. The order allows nurses and licensed practical nurses to order throat and nasal swabs and authorizes licensed practical nurses to practice at the top of their training without a registered nurse supervision. So this really frees up the highly trained healthcare workers we have and helps relieve a lot of the strain on the system. But the cool part is that reforming the scope of practice certainly matters during normal times too. Michigan has several areas with shortages of primary care physicians, and research shows that it's unrealistic to rely on the physician workforce alone to provide primary care for Americans, especially as we see primary care physicians retire and we aren't able to replace them fast enough. So essentially, scope of practice laws continue to do they do a lot of things that we don't like to see in healthcare, which is they're increasing our wait times, they're increasing prices, they're restricting access, they're reducing choices, and they don't maximize customer service.
Historically speaking, why have these regulations been so difficult to reform? Where does the pushback come from? And what are the things that are often brought up in opposition to reducing these regulations?
Sure. So as most of you guys know, our system of government typically makes reforming laws quite a slow process. And there's a lot of good reasons to that. The fascinating and encouraging part about reforming scope of practice laws is that both sides, whether they're pro or con, they agree with the problems that I've described. So provider shortages, cost of providing care increasing, accessibility issues, they just can't really agree on how to solve them. And when you look at nurse practitioners and physician's assistant laws specifically, primary care doctors have a unique ability to influence the licensing process of their direct competitors and healthcare colleagues. So what I mean by that is it makes the reform even more difficult, and the fact that Americans just, they flat out trust doctors. So according to a 2019 Pew Research poll, nearly 3/4 of Americans today have a positive view of medical doctors. So when doctors speak, Americans tend to listen, and that means lawmakers do too. So hypotheticals from respected physicians who in many cases are practicing in the same districts as those lawmakers are serving on particular House committees or Senate committees, they can really discourage policymakers from changing the status quo. I saw this quite often when I was a policy advisor for the Michigan Speaker of the House a few years ago. And so if doctors say it isn't safe, lawmakers tend to listen, regardless as to what the studies show, and regardless of the fact that almost half of states safely allow nurse practitioners to operate full practices up to the scope of their abilities. So there's good news, though, that I think we can take away from the fact that these are hard laws to reform, is that Michigan recently has done some work revising our scope of practice laws. In 2016, NPs were given the authority to prescribe medication, in some cases with and some cases without the designation of a physician. And so this, coupled with like the new executive orders from the governor, really show that Michigan's moving in the right direction.
What's the main difference then between scope of practice limitations and general licensing restrictions, which Governor Whitmer also made changes to, and we briefly mentioned at the beginning of the call?
Sure. So recapping, scope of practice restrictions prohibit healthcare providers licensed in Michigan from practicing to the full extent of their training. And the executive order suspended some of these restrictions for nurses, NPs, PAs, nurse anesthetists, and pharmacists. But her order additionally also suspended licensing restrictions that have prevented high-quality nurses, doctors, and other providers located outside of Michigan from practicing here without first getting a Michigan license. So now, temporarily at least, licensed providers from any state are able to practice here without a Michigan license. And what that do is it encourages providers from areas or other states that haven't been hit as hard during the health emergency as we have in Southeast Michigan to come to Michigan and begin caring for patients immediately. There's no waiting in line to get a Michigan license. And so both the suspension of scope of practice restrictions and suspending that requirement have really done a good job at sort of relieving some of the stress on the system as much as possible. And so that also carries over to times of normalcy, because it'll create larger pools of providers and caregivers.
Thanks, Greg. This time I want to direct everyone in the audience's attention to the top right-hand corner. You'll see a chat button. If you want to submit a question for either of our speakers or both of our speakers, please feel free to start doing so via the chat function. And while we wait for those questions to come in, a couple of more questions to Lindsay and Greg. Start with Lindsay. I've heard that certificate of need laws are needed because they, and you alluded to this, they improve the quality of care people receive. In fact, people are seeing the best in the business for certain critical services because not any facility can just open up a NICU wing, for example. This is one of the common arguments that you hear. What are your thoughts about that and the ability for hospitals, which we see in states that have certificate of need laws, to essentially have a veto over any competition coming into their marketplace and being able to stop any new competitors from coming in using the certificate of need laws?
Mm-hmm. Yeah, well, first of all, certificate of need can be a very complex issue to break down and to understand. So I'll just give you a really simple analogy. Imagine that Publix wanted to open a new center. Let's say they want to open it in Midland, and they have to go to the state. A bureaucratic board, so unelected officials make up this board, and they go to the state and to the board, and they apply to open this center. Well, on that board sits representatives of all of their competitors. There's somebody from Kroger, and there's somebody from Whole Foods, and your Aldi, and several other grocery stores sit on that board. And that board is in charge of determining whether or not Publix gets to open this center. And not only that, but Publix has to pay an extraordinary amount of money to even file a petition to open the center. And when they go before the board, their competitors are actually invited to come and testify as to why they're not needed. So you have Kroger and Whole Foods showing up and saying, you know what? I'm Kroger and I'm already here. I'm just down the road and I'm already selling groceries at a pretty decent price, we think. Publix really isn't necessary. And Whole Foods coming in and saying, you know, not only are we selling groceries, but we hear that as part of this store, Publix wants to have a special aisle dedicated to vegan products. We already have that. In fact, we have 2 aisles dedicated to vegan products. And so they're really not needed. And especially, you know, if they're even approved for this plan, they should not be able to have a vegan aisle. That is how certificate of need works, and it's the most absurd process because obviously a scheme like this would restrict access, would drive up costs, and it lowers quality because when you don't have competition, there's less pressure on the providers to actually perform quality services. And so research is now finally available. There was a lack of research in the beginning about how these laws would actually impact, patient care, but emerging research is now showing that deaths, for example, from treatable complications following surgery and mortality rates from heart failure, pneumonia, and heart attacks are all statistically significantly higher among hospitals in certificate of need states than hospitals in non-certificate of need states. And also in states with especially comprehensive programs like Michigan's, patients are far less likely to rate hospitals highly.
And we've seen, and there's a great analogy you gave, we've seen how delicate our supply chain is in just delivering food to people. And that's in a mostly unregulated marketplace in terms of grocery stores. So you can imagine why there was such panic about our hospitals being overridden with patients because there was a major issue of supply, being able to deliver care, critical care to the patients that need it. We've got our first question from Brad, who's asked, as an employer, our healthcare costs have been going up 7 to 10% per year. How do we make sure that healthcare costs don't explode post COVID-19? I'll open it up to either Greg or Lindsay, whoever wants to comment on.
Sure, I'd be happy to take a stab at it. At FGA, and I know Mackinac Center is working on many of the exact same solutions. The idea is that to stop costs from exploding, we need more choices to choose from, and we need to give the healthcare market specifically, more flexibility. So I'll just kind of briefly discuss a couple other solutions that are helpful besides scope of practice and data need reform, and also the licensing one we've all discussed today. So one of the other solutions I've written about is that is expanding short-term plans as a bridge for those who are out of work or without insurance. So short-term plans are essentially plans that you can purchase year-round. There's not an open enrollment period. You don't need to trigger a life change for that to happen. You can purchase them right away. They can cover interruptions of workplace coverage. They're about 60% less expensive, and they cover sort of the emergency things that you would need in care. They are not new either. The standard of having them isn't new. In fact, they've existed for about 20 years until basically before the 2016 election, when the Obama administration prohibited consumers from buying them for longer than a 3-month period of time. And so Michigan's law, if we're looking at reforming Michigan's law, it's specifically limited to 185 days for a single purchase of a plan, because the Trump administration opened to back up short-term plans through a rule change. And now our law says you can purchase them for 185 days, but you can't renew with the same provider, and it's not allowable up to the 3-year period like the Trump rule. And so that's one area where you can really sort of save money and provide coverage at a much lower rate. The other one, and especially for an employer, would be an association health plan. And so federal rules have changed. They've extended or expanded the ability to join those groups. They're essentially ways for small businesses to join together collectively to reduce costs by acting as though they're a large employer. And so you can reduce a lot of the premium costs and things like that. And so adding access and providing more options through those two is a great way to kind of open up the market. So there's several things that can be done. The things we've discussed on the call today, and then short-term plans and association health plans are also great additions to that. And Lindsay, feel free to add anything.
Sure. I would just add that a lot of this work, unfortunately, also has to be done at the federal level. So as Greg mentioned, there are some things that the state can do, some added flexibilities we could take advantage of. But unfortunately, a lot of the really hard and significant work has to happen at the federal level to roll back some of the mandates involved with the Affordable Care Act in particular. Chief among those are the essential health benefits that the federal government mandates are part of every health plan. That drives up costs significantly, and there's very little that the states can actually do about that. There's obviously been gridlock in Congress on healthcare reform for a number of years now, but that just really that should show us how important it is that when states do have the flexibility, because we have so very little of it with regards to healthcare reform, such as the association health plans or the short-term health plans, we need to take advantage of those. Because every little bit counts, and states should be showing that we're interested in exerting more autonomy over our healthcare markets.
That's such a great point.
Next question is from Carl, and we just ask if you're viewing the event, just to mute your microphone if you log in. Just to make sure that we can hear the speakers. Our next question is from Carl. Doesn't certificate of need, when used properly, reduce costs? So, for example, two Da Vinci robotics used 25% of the time is more costly than one operating at 50%. What are your thoughts on the cost to businesses that try to expand and the technology costs, and that being an impediment to delivering critical care services, and that being one of the arguments for certificate of need?
That was one of the original arguments for these laws. And after being in place for about 20 years, the federal, or even less than that actually, the federal government realized that they weren't working. They simply weren't effective at controlling costs. CON regulations increase per service and per procedure health costs. Research is now showing that. Even though CON regulations might reduce overall healthcare spending by reducing the quantity of services that patients are consuming, the balance of the evidence is showing that CON laws actually increase total healthcare spending. In fact, the latest research is suggesting that that Michigan without CON would be spending about $215 less per person per year on healthcare. That doesn't sound that significant, but when you have all of these compounding healthcare costs for the state and for the individual, that's an important figure to keep in mind. So preserving these laws, which we know been proven ineffective, though the intentions were, at least admirable, I suppose, when they were originally implemented, just doesn't make sense anymore.
We have another comment in the chat room from Rich, who raises the issue of cost of technology, similar to Carl's, and additional hospital expansion and the cost of being able to break even. One of the adding to that comment, we're noticing a lot of hospitals are furloughing what are considered non-essential employees for them at this time because of the strict focus on COVID-19. A lot of other care areas are essentially furloughing their nurses and doctors and other personnel and having some significant financial challenges during this time. So do you foresee, in terms of expanding healthcare services, state subsidies as something that we may hear about post COVID-19?
Well, we're definitely going to see a lot of subsidizing happening within the healthcare space. We're already seeing that happen during this crisis. We're going to see that happen exponentially in the wake of this crisis. You know, hospitals are already heavily subsidized, both by the state and the federal government. So there are a lot of funding streams that go into making up hospital revenue, and a lot of that, actually disproportionate amount of that, actually comes from the federal level. But it's important to remember that hospitals are like other businesses in some ways, and unlike other businesses in other ways. But, you know, a bottom line principle that really underscores why CON has been ineffective, for example, is that they have to make decisions that are appropriate for their individual centers. And so when you have these one-size-fits-all regulations coming down from both the state and the federal government that, you know, mandate certain access to care, for example, for Medicaid patients and Medicare patients, where reimbursement rates are shifting, and oftentimes reimbursement rates aren't adequate to cover the full cost of seeing those patients, but there's still these blanket mandates on certain access for those patients, both for clinics but also for emergency rooms. As we know, there are a number of drivers to those increased costs, increased needs for subsidies. Is really just, it goes back to the big overwhelming need we have for federal government to roll up their sleeves and do some really hard work on reforming the healthcare system. And it shows how inadequate the Affordable Care Act was at actually doing that. I mean, that was sold to the American public as being the solution for access, quality, and costs for care across the country. And we know that hasn't been the case. And while hospitals often bear the brunt of that, they're sometimes the culprit as well, in that they're not forced to balance their bottom lines as they should be in some cases. There's there are some perverse incentives for them to pursue federal dollars or state dollars by, acquiring clinics or, incorporating and things like that actually increase needs down the road for more subsidies. So this is a bigger topic than what we have time for today, certainly, and it is very complex, and there's no one solution to it. Both the state and the federal government need to have a hand in coming up with those solutions, but it's not easy, and obviously it's so dependent on movement at the federal level.
Lindsay, you mentioned the federal level, and perhaps you or Greg can answer this. What of the recommendations Mackinac Center has been making, what would you say you've seen taken under consideration by the federal government in their approach to this issue, and the executive orders that they've put out there to try and solve some of the supply shortages and regulatory challenges in delivering critical care services and drugs? What are your thoughts on that, or comments on our work federally?
Sure, I'll let Greg kick off there, because he's been doing a lot of work that's both multi-state and impacting federal conversations, but I'll be happy to chime in.
Sure. So we recently post the coronavirus, we've really had to sit back at FGA and kind of figure out what do we do now that state legislatures have sort of shut down or meeting in very limited sessions. And so we've begun kind of this brainstorming session of looking at areas of healthcare reform, workforce reform, and welfare reform specifically too, of regulations that have flexibility that can be modified and changed. And so we've really just kind of dug into that process, but we are looking at how can we bring more price transparency into healthcare? What areas in terms of like, whether it be HSAs or FSAs, is there flexibility in regulation to open those up to more plans or larger uses, things that can save people money? Let me think here what else we've been kind of focusing in on. Is there any, we're looking at flexibility in outside of the Affordable Care Act, because that's just a monstrosity that we haven't really begun to tackle at that level yet. But is there, in large group plans or in association health plans, is there more flexibility that can be given? Those are kind of our focus areas right now. And again, we've just dug in at the federal level to do that. Mm-hmm. And so we'll see as those options develop, kind of more solutions present themselves, because we've done a ton of work state level, but obviously that's really slowed down. And as Lindsay mentioned before, a lot of the limited flexibility is there, and some of it is congressional, but what can be done administratively and executively that allows some sort of more flexibility, more market-based solutions from what the framework we've been given.
Yeah, and I would add,
go ahead, Lindsay.
Yeah, in 2018, the Trump administration actually issued some guidance that was put together by multiple departments, Department of HHS, CMS, Department of Labor, on what states could do around the ACA, around the federal construct, to increase access, quality, and affordability of care. So there are a number of recommendations in there that states actually have the power to pursue. Among those, obviously, is repealing certificate of need. There are recommendations like passing direct primary care, which Michigan has done. So there are some market-based opportunities states can take advantage of, and those are all outlined in that report. And what's really encouraging about that is that really marked a pivot in the tone that states were hearing from the federal government. So up to that point, and especially during the Obama administration, states were increasingly being told no. So when they sought flexibility from the federal government through waivers, 1115 waivers are the most well known for being the vehicle for work requirements, for example. But there are 1332 waivers that can allow states to get somewhat innovative with their healthcare marketplace. Most often, states would be sending these in to the Obama administration and hearing back, no. And so it was really discouraging. So states, and a lot of states actually stopped pursuing increased flexibility because they were told no so consistently. But the Trump administration's posture is really different, and they have been encouraging states to get innovative with what they can do and sort of acknowledging that the gridlock at the federal level is unlikely to change anytime soon. So short of there being action there to reform the ACA, they put out a list of reforms that most groups like the Mackinac Center, FGA, and other state-based free market organizations around the country have been sending their way for years now. We've been screaming on the sidelines for these types of reforms for years. So when there's been opportunities to reform guidance at the federal level or regulations that the executive office itself has impact or has the opportunity to reform, the Trump administration's actually been doing that, and that's been very encouraging. So while it's sort of throwing little breadcrumbs at us states, it's better than nothing. So if anybody on this call is interested in seeing what the administration's put out there to tell states to take advantage of, that's a report that I think is it's definitely one I would recommend and has a lot of great stuff in there, most of which the Mackinac Center has been out championing for years as well.
They also haven't. Oh, go ahead.
Go ahead, Greg.
I was just going to add to that they are really, the Trump administration hasn't been shy about reforming the areas that they also can influence, which is Medicare and telehealth and Medicaid. There's like the waivers that Lindsay mentioned for Medicaid, but then there's also this flexibility where Right now, telehealth's allowed in Medicare, but it's limited, and so they've been opening that up during this crisis too to see, how can care be delivered that way as well when it's medically possible, of course. And then the VA's had quite a bit of success with expanding telehealth as well. So all very encouraging.
Greg, you mentioned earlier about price transparency, something that you folks were looking at. We have a couple of questions in the chat room about price transparency, and that being one of the drivers of increased costs, particularly on things like MRIs. The Oklahoma Surgery Center comes to mind as a great beacon for the rest of a great model for the rest of the country as to what price transparency can do for as a healthcare model in a positive setting. What are your thoughts and comments on implementing price transparency, medical billing transparency in Michigan and around the country?
So I guess the first thing that comes to mind for price transparency really is when I was doing research on direct healthcare or direct primary care, how upfront those pricing models really are, and also like how upfront the services that they provide within the fee schedule or within their pricing model. So those are really encouraging models that have been developing across the country. It's growing at a really good rate. I believe, and I haven't checked this in a while, but I think there was a rule that came down through the Trump administration that was requiring hospitals to provide, Michigan hospitals were going to have to start providing more transparency. And I haven't followed up on that lately, but I know that one of the questions asked about activity in Michigan specifically. And I believe that there is action from the federal level that's kind of driving that price transparency down into the states. And so we'll see a lot of lawmakers want to do this. We actually have a reform that we haven't worked on in a while that we've kind of brought back up to revamp, and it's called Right to Shop, where if a consumer is able to find a service for less, they can kind of benefit from those savings, whether it's in network or out of network. And so there are unique models, and that's one we've worked on in the past, but it just took it wasn't getting a ton of traction outside of some public sector employee changes. But now, as prices have been skyrocketing, as one of the attendees mentioned, as the employer seeing skyrocketing healthcare prices, people are more interested in bringing transparency out in those prices so they can shop, because I think the big thing now is no one really knows until they get the bill, right? Like, you really don't know what you're paying for until it comes to you in the mail, and you're hoping that it's part of a small deductible or part of a small copay.
Yeah, I would add to that.
Go ahead, Lindsay.
Another form of transparency we've been really diving into, especially lately, is the issue of surprise medical billing. I'm sure there are people on this call that have gone to receive a service. They've even maybe priced out in advance. They've called to make sure that whatever surgery or procedure they're obtaining was going to be in network. They were given a relative approximate cost, and they thought they had been proactive and responsible. And then they come home and they get that bill in the mail, sometimes 2 months later, and all of a sudden there are all of these other costs there that they were never expecting and were never told about. So that's what we call surprise medical billing. And and it's a real problem. I mean, it can be crippling for people financially. And probably all of us have experienced some level of this at one time or another. The issue with that is, as Greg noted, there has traditionally been very little transparency required of hospitals and insurance companies and their negotiated prices to release exact costs to the public. Part of that is by design. In fact, I would argue that all of that is by design because it allows hospitals and insurance companies to collude and really pad their bottom lines in a lot of ways. So while their intentions may not be nefarious, the end result is that patients end up getting taken advantage of, and they're left in a really difficult spot. And so when you call and you actually take the steps to try to obtain real information about procedures you're obtaining through any healthcare facility, there should be some sort of responsibility on your provider's part to give you an approximate cost that's not significantly different than the end cost that you're stuck with. So while there may still be some variables, there are some unexpected things that happen from time to time. You go into procedures, and we in our proposed modeling of reform for this would account for the fact that there are often mitigating circumstances, but there are often not mitigating circumstances as well. There are just simply there's simply an obstinance on the part of hospitals and insurance companies to get it right and to treat the patient with the respect that they deserve. So there's emerging legislation in a number of states now trying to address this. It has to be done delicately, at least from our perspective, because as a free market organization, we don't like mandates. So we don't want to put restrictive mandates on facilities and insurance companies that force them to be more transparent than what is necessary for patients to have their rights respected. But it is an issue. It's a very real issue. In fact, when in national polls, when they dig into healthcare issues, surprise medical billing is at the top every time for the last several years now, because so many Americans are impacted by this. So that's something I would just suggest that everybody on this call just kind of keep a lookout for. It's something that we're going to be taking deeper looks at ourselves.
Thank you for that clarification, Lindsay. We've got a question in the chat room from Dr. Zako, and this one's for Greg, who stated earlier about scope of practice legislation limiting the ability of nurse practitioners and PAs to practice up to the scope of their training and capability. If this is true, why not totally eliminate licensing requirements for all health professionals and allow anyone to practice as a physician? Greg, what's your response to that? Did we lose Greg? Lindsay, did you want to comment on that while we wait for Greg?
I'm sorry, I had it
okay.
muted there while Lindsay was talking. No, I'm happy to address that. The scope of practice reforms, they're not about eliminating the need or allowing anybody to practice as a physician. What they're doing, and what specifically the laws restrict, are the ability for NPs or PAs to practice at their full extent of their training. Which isn't the full extent of a physician, right? And so there are markets for both in the primary care space. If there weren't, we wouldn't see nurse practitioners or PAs working alongside physicians. So the idea isn't to eliminate those restrictions entirely so that they can just go out and practice as a physician. The idea is you're opening up choices for healthcare consumers to utilize, and you're bringing some of the basic necessity care to individuals that wouldn't otherwise be seeing a doctor. For instance, there's research that shows that specifically in Michigan, more folks will be going to see an NP or a PA to have something looked at. You would be reducing wait times. The costs of seeing those providers are less because the preparation time to become them is less. And the acknowledgement here is not that they're exactly the same as a physician and the knowledge they have is exactly the same. It's that within their scopes, they provide healthcare services at the same outcome as a physician would within their scope. And so that's the point of eliminating those restrictions, not that doctors are no longer necessary. It's actually the opposite of that. It would free those physicians up to practice within their scope and collectively work together as well. But the fact that almost half of states allow a nurse practitioner, for example, to have a full practice doesn't mean that this NP never refers anyone to a physician or is practicing illegally. There are high ethical standards that all of those healthcare providers must attain to. And so, no, it wasn't about eliminating the need for a physician at all.
Yeah, and expanding on that, I know here in Florida, a legislation that was just passed that allows pharmacists to test for something like the flu, which also takes burdens off of doctors and other healthcare providers. And it's things like this that obviously alleviate some of the backlogs that we see during high flu seasons or pandemics like what we have with COVID-19. One of the questions we have in here from Robert is, why does Florida have almost double the costs on Medicare rates, double the Medicare rates than Michigan does? Not sure what he's citing on this, but his question is why Florida's Medicare rates are almost double what we see in Michigan.
I guess I would need to better understand the question. By rates, is that asking, the number of patients who are on Medicaid or individuals receiving Medicare, or is that the costs for paying for those individuals on Medicare?
I think it's the cost. I think it's the latter. The question is on the cost.
Well, Medicaid and Medicare reimbursements are, of course, determined at the federal level. They do take into account the cost of receiving care in those states, and they average that number. So very likely, and I haven't looked at Florida in particular to confirm this, but likely that's the reason, is because the cost of living and establishing facilities and providing care in Florida is a bit higher than in Michigan, and so the reimbursement rates are going to be different for that reason. But there may be some other issues there too, and I'd be happy to take a look.
Right. Question for both of you: if you could make one of Governor Whitmer's or the federal executive order reforms permanent state and or federal policy post COVID-19, which ones would that be? And we'll start off with Lindsay on that question.
Sure. Well, if you haven't noticed, I am particularly outraged by certificate of need laws. I just think that they put the needs and the interests of the patient last. And so I would urge that to be the first area of focus for the Michigan legislature when they come back to work, is to make that EO reform of Governor Whitmer's permanent.
Greg, to you, what are your thoughts on the state executive order? What one would you make permanent? Which of the regulations that have been lifted would you make permanent? And or at the federal level, which would you make permanent to help ease the burden on our healthcare industry?
Sure. So since the person asking the question is giving us both one, I'll pick something different. So we'll both have wishes granted, hopefully. I think I would pick the licensing restrictions for across state lines. So a lot of, when you think free markets and you think free enterprise, a lot of it is just the movement of goods and resources and services. And so for me, the workforce reform there opens up a lot of, it reduces a lot of the barriers inherent in like the ability of physicians and providers to move throughout the country as easily and as efficiently as possible to provide for Americans who need those services. And so I think it's a great reform at the state level to allow, high quality providers, and we're talking those that have licenses that are from other states that are in good standing, that haven't been revoked, and haven't had any investigations, things like that, where when there is a pandemic, when there is an emergency, those folks can come in almost like first responders do, right? And take care of Americans' healthcare needs. And so the barriers and the workforce stuff, I think it's a double whammy in that regard, where you got healthcare help, but you're also helping on the workforce side as well.
Yeah, and could I give an honorable mention? This
Sure,
this is actually one that has not been done yet, though we are urging the Michigan legislature to do this actually, because we feel like it's within their power to do. But we have heard chatter nationally. There's been reports that hospitals across the country have been colluding over an idea of how they could address mounting patients diagnosed with COVID and protect their staff. So at policy, they've been talking about implementing that would be nationwide preemptive blanket policy, would be that if a COVID patient medically codes in their facility, meaning they need life-saving protocols, which are standard in these facilities, but do subject medical personnel to even more intimate interaction with the patient than they would otherwise have. If patients code and have been diagnosed with COVID, the hospitals would have a preemptive do not resuscitate policy, no matter the circumstances, no matter if the patient had already requested, as you have the right to do, the desire to be resuscitated should they need to be, or their legal guardian has made that request. It is a discriminatory, unnecessary policy, and it is something that should be legal anyway, but as we've seen with the expansion of powers and what happens in a crisis, often power is grabbed from different places at different times, and before you can prevent it, it's already happening. So the Mackinac Center wrote model policy that says, not in our state. Our patients have the right to pursue life and to have that right respected. And that's a policy we've now given to the legislature. We hope and expect that they'll take that up when they come back in session. And we've provided it to other states as well. But the federal government's been paying attention there too. And when we issued this model policy, we got a call from the White House saying, what can we do? And a couple of days later, the Office of Civil Rights in the Department of HHS actually issued a bulletin saying, this is a shameful practice, should it be implemented? And they discouraged such a practice from ever taking place. So this is a policy that hasn't been adopted yet in Michigan. It is something that a couple other states have now adopted, but I would put that out there as something that I think needs to be permanently adopted, put into Michigan statute so that we never have to talk about it again.
Great. Thank you for bringing that up. Lindsay, I have one final question for you, if you could speak quickly to this one. Mackinac Center was part of forming a coalition with the Michigan Freedom Fund and the Great Lakes Education Project on COVID-19, a blueprint for health, safety, and economic opportunity during this crisis. Could you speak quickly about what that entails and what we're trying to accomplish there?
Sure. Well, in addition to the healthcare policies that I briefly mentioned at the outset of the call that we provided to the administration and legislative leaders to address the healthcare needs of Michigan patients, we expanded those recommendations to include everything from economic and labor-related reforms the state could adopt that would provide both immediate relief and make sure that we can properly recover in all sense of that word from this crisis. And that was a document that we've published on our website. If you have an interest in seeing what other things Michigan can do to adequately to come out of this crisis, then you can go to mackinac.org, but it is a coalition-led document, and this week, in fact, we'll be producing a sort of second iteration with some other coalition partners in the state. The Michigan Chamber, for example, is going to be a part of that in addressing more specifically the governor's latest extended executive order, which is more restrictive in nature and has a wider impact on the livelihoods of Michiganders. So there'll be some new things in there, some guiding principles, and later this week there'll be some more details on specific policies that we believe the legislature and the governor need to be immediately acting on.
Right. Thank you, Lindsay. Greg, any final comments from you before we wrap up?
No, I think we got a lot of discussion. The healthcare topic is so broad and so deep that there's a lot of flexibility. There's a lot of room to make, even amongst divided governments, things freer, more market-based. And you can see that, I guess, the cool part about seeing some of these executive orders is that in times of emergency, Americans just kind of do what's right. and they start to reduce those barriers that prevent care. We have a gut reaction to kind of do things that are necessary to save lives, provide better care. And so I find this as an opportunity to really push forward with a lot of the reforms that have kind of been on a standstill. And so I'm excited about it. And if you're looking for any of the work that FGA has been doing, we have our website, which is thefga.org, and all of our solutions, including some of the short-term ones here post-COVID-19, are available on that website. So thanks again for having me too, by the way.
Thank you, Greg, and thanks for mentioning the website where we can find your work. I'll also mention, if you want to follow what the Mackinac Center is doing regarding this issue, you can go to our website, mackinac.org/COVID, and you'll see all the things that we discussed today on the website. I mean, you can continue to follow us there and our responses to this ongoing issue. In addition, next week we'll be back here next Tuesday discussing labor policy. That has been a really hot button issue for the Mackinac Center for our history, but there have been some other issues that have arisen during this crisis with labor unions that I think you're going to want to hear about from one of our resident fellows, Vincent Vernuccio, who's going to be speaking to that topic, and you'll be able to find information on that via our website, mackinac.org, and you'll /events, and you'll be able to see all the events we have planned through the next few weeks as all of us are cooped up in our homes, looking for ways to entertain ourselves and educate ourselves and prepare ourselves. The Mackinac Center is here to be able to try to provide a solution towards that end as well. And none of that would be possible without all of our supporters, many of whom are on this call, and thousands of others in Michigan and around the country who make our work and our success possible. Without you, none of it would be possible. So we thank you for that, and thank you for joining our first event here with the Mackinac Center, Tuesdays with the Mackinac Center, and we hope to see you next week. Take care, everyone.